It's a couple of minutes past 2 now, so we might get started. So hello everyone, and welcome to the Wolfson Centre Clinical Seminar Series. So this is a series that runs twice a year, and it's aimed at practitioners working in the field of young people's mental health. So I'm Olga, and I'm a clinical research fellow at the Wolfson Centre, and I'll be introducing our speaker today. So, but before we do, I just wanted to let you know the seminar is going to last about an hour. There's going to be a 40-minute talk followed by around 20 minutes for questions and discussion. And if you do have any questions as we go along, you can put them in the Q&A box either during the talk or after the talk. Okay, so now I'm going to introduce our speaker. It's my pleasure to introduce Professor Samuel Cortese. He's an NIHR research professor and Professor of Child and Adolescent Psychiatry at the University of Southampton. He's also an honorary consultant for Hampshire and Isle of Wight Healthcare NHS Foundation Trust and a Professor of Child Neuropsychiatry at the University of Bari in Italy. So his research focuses on neurodevelopmental disorders, particularly ADHD, and he has contributed extensively to the field with over 450 peer-reviewed publications. He's been involved in securing more than £23 million in research funding as a lead or co-applicant and is recognised among the top 1% of scientists in psychiatry and psychology since 2022 and also identified as a leading expert in ADHD. He also currently serves as chair of the European ADHD Guidelines Group. And so today, Professor Cortese is going to talk to us about how can the evidence base inform clinical decision-making in the pharmacological treatment of ADHD. So thank you very much, and I'll hand over to you, Sam.
Thank you very much, Olga, for the nice introduction, and good afternoon, everybody. I'm very pleased to be able to provide this talk, which I hope will be helpful for your clinical practice, and if you do research, also to provide some ideas for future avenues of research. I'm going to share my slides. Here we go. Right, so these are my possible conflicts of interest, and let's move then to the talk. What I will try to do is what I will call the evidence-based, the journey actually of the evidence-based ADHD prescriber. What does it mean? That, of course, when we treat ADHD pharmacologically, we go through a series of steps from the initial choice of the medication, the dosage, titration, and so on and so forth. So the question is, to what extent can evidence inform this decision in clinical practice? So I will go actually through these specific aspects. So the choice of initial medication, the titration, the follow-up, the so-called complex ADHD. I will explain better what this refers to, how to stop and when to stop medication, and how to manage the side effects. And once again, the focus is really to understand what does the evidence tell so far, and to what extent actually evidence is able currently to inform this decision making. So let's start from the initial choice of medication. I guess everybody is familiar with these recommendations from the NICE guidelines 2018, slightly modified in 2019, but they're more or less the same. And of course, when it comes to the treatment, the first step is what they call the group-based ADHD focus support. Nobody really understood what this is, but basically it's one session or 2 sessions of psychoeducation, basically. But then the recommendation is if there is still a significant impairment, and I'm aware that individuals with lived experience don't necessarily like the term impairment, but this is what NICE used back then, in at least one domain of life to start medication with a specific hierarchy, as you can see here. So methylphenidate as the first line, Lisdex or other amphetamine, dexamphetamine as a second line. And if this does not work, or it does work, but it is not well tolerated, then move to atomoxetine or guanfacine. I guess that everybody is familiar with this hierarchy. This was in part informed by a series by a meta-analysis we did back then in NET, because we know that if we look, for instance, 100 children with ADHD, roughly 40% will respond equally well to amphetamine and methylphenidate. However, around 28% will respond better to amphetamines, and then around 15-16% will respond better to methylphenidate compared to amphetamine, and the rest will not respond. And among these, 50% will respond to atomoxetine. So unfortunately, currently, after more than 50 years we use the stimulants, we do not have any predictor, clinical, genetic, biological, and so on and so forth, that can tell us how to choose medication. So we should appreciate, of course, that this order is just the first indication, but certainly you may end up with patients for whom atomoxetine or guanfacine may be the best choice, but you don't know this in advance, of course. And there's been the suggestion that pharmacogenomics may help on this. This has been a dream, but it currently is not reality yet, because there is no strong scientific evidence to support the use of pharmacogenomics to guide the selection of medication. So you may well see adverts and websites like this one that, if you spend just $299, you will find the best medication for your child with ADHD, but this, as I said, is not endorsed by scientific societies. It's not just a matter, of course, of choosing the compound, but it is also a matter of choosing the formulation of the medication. And everybody, I guess, is extremely familiar with the different formulations available on the market. I have to say that it's interesting to see that in the past years, there's been an explosion of different brands, or so-called generics. So it's quite difficult to stay on top of this. But I guess that these curves that I show here in terms of the bioavailability of different products of methylphenidate are quite well known to you. So I guess that everybody will be able to I guess that the green one refers to methylphenidate concerta, basically, so where 22% is immediate release and 78% is extended release. So, everybody is familiar with this, and when we discuss with patients, we try to tailor their expectation, their need to what we know about the theoretical duration of action of that formulation. So if somebody say, for me, it's very important to reach also a good control of ADHD symptoms in the second part of the afternoon, we will probably choose the green one. However, and I guess once again, everybody has experienced this in their clinical practice, these curves are just kind of averages and to some extent extrapolation between different points. In reality, there is a huge variability, so that it is not surprising to see some individuals for which, for instance, concerta lasts 4 hours. So ultimately, we learn with our patients and their family how to tailor really the medication. But it goes through a series of trial and error. And everybody, I guess, is doing this. So we try really to combine different formulations of methylphenidate in this case, really to tailor the need of that specific patient. You see, with an immediate release, for instance, early in the morning, many families, I'm sure you hear the same, tell me, early morning is probably the most challenging period in the day, because the child needs to get ready, but it's a mess. And so it would be good to have a coverage then. In the United States, for instance, there are formulations that you give them in the evening before, and they start being active early on in the morning. So that will be extremely helpful, but we don't have yet here this kind of formulation. So we do whatever we can with our available formulations, as you see here. Right, so let's assume that then we have found the right medication for that particular patient. A crucial step is the titration, because needless to say, if you use a medication at the dose which is not the right one, you will not have the expected effect. Now, the question is, up to where shall I go with the titration? What is the maximum recommended dose? We have done some there are quite complex analysis called dose response network meta-analysis, but in a nutshell, they tell us, how the medication is effective and tolerated at different dosages. So if you can see here, this curve on the left-hand side is about efficacy. So you see that the more you increase the dose, the more you have a reduction in the severity of the symptoms. If you go beyond the threshold, which is 60 milligrams, 60 milligrams is the maximum licensed dose of methylphenidate in this case, you still have a benefit, but you see the gain is quite small. So we can say that on average, once again, these are group averages. If you go beyond the 60 milligram a day, you should not expect massive improvement, but there may be some individuals for whom actually the dose of 70 or 80 is the only one which is effective and they tolerate it well at the individual level. But at the group level, we have this. Likewise, at the group level, this curve is related to tolerability. You see that if you push the dose beyond the 60 milligram, you start paying a price in terms of, decreased tolerability. So in general, we do not recommend to go beyond the maximum licensed dose, but in some individual cases, especially for those cases where when you are at the maximum dose, you see some kind of improvement, is well tolerated, but you would like to see more, then it's okay to go off-label. You need to inform the patient, of course, and the family that it's off-label, is an off-label use of medication, but it may provide a benefit. So, as I said, we don't have any predictor that tell us, what is the best dose for each individual. So what we can do is to make sure that every patient is exposed at the beginning to different types of dosages. And so this is what my friend and colleague David Coggill used to do when he was still in Dundee in Scotland. As you may know, he moved to Australia some time ago. But they used to implement a clinic whereby there was a 4-week titration with weekly dose increments. So, first week, let's say 18 milligram of Concerta, so to speak. Second week, 27, 36, and last week, 54 milligrams. And then you see the patients and you ask them, tell me which was the best. If we don't do this, the risk is that to do, as some prescribers do, you start a low dose and you go to a moderate dose, there is some kind of improvement and you stay there. The goal is not to have some kind of improvement. The goal is to have the best benefit, the best really decrease in terms of benefit, in terms of symptom severity. So we need to, we need to optimize the dose rather than being satisfied with some kind of improvement. So it's very important to make sure that we know which is the best dose for everybody. Because in my experience and also in other experience, even sometimes a change of 10 milligrams may make a huge difference to that particular child. Right, so then once you have done the titration and everybody is happy, you have found the right medication, you have found the right dose, then of course you want to do a periodic follow-up. One important question is, shall the dose of medication change over time? So let's say I see a child now and then I will see them in 6 months. In 6 months, shall I change the dose or not? Well, we know this is a nice study, a nice analysis of the MTA study, which was still is a very important study in the United States. Originally was a trial, then it became a naturalistic cohort observational studies. So basically, as you can see here, after the first year when they were still titrating the dose, after this, the dose, the milligram kilo was stable, which means that once you find the best dose for every child, you should try to stick at the same milligram kilo. Going above that may expose the child to high dosage with the risk of possible induction of tolerance. I would like to clarify, this is not to say that you need to make the initial dosage based on the kilogram, on the weight, because there are some children who are young and thin and they require high dose, and some adolescents who are quite big and they are okay with relatively low dosages. So the initial dose is not body weight dependent, but then once you find the dose for that particular individual, you should try to stick to the milligram kilo dose. This is a table courtesy from my colleague Dr. Adamo, who was working with David Coghill. So I think we became quite familiar with this, sadly, due to the national shortages. So this is about the equivalence. So how do we switch? And so the key message here is that when you need to switch from one formulation to another, what you should look at is not the total dose, but the immediate release portion. So let me explain this with an example, which hopefully will clarify things. So if you want, let's say, to switch from Equasim XL 10 milligram to Concerta, the equivalent dose of Concerta is 18 milligrams. One would say, well, actually it's nearly double, so it's not equivalent, but actually it is, because the immediate release portion of Equasim is 3 milligrams, and the immediate release portion of Concerta, as we saw early on, 22%, so it's 4 milligrams, so it's basically the same. So this table has other examples, so it should help you with the conversion. Right, so far, so we are very happy. We found the right medication, we have titrated properly, we have followed up properly. All this relates to cases of ADHD, which are the so-called easy cases. But we know that actually in our clinic, we always see a kind of complex ADHD. I can't remember having seen a case I label as straightforward. So what does complex mean? It's not an official definition, but in a consensus conference, it was agreed that basically complex ADHD referred to cases with comorbidities or also preschoolers, which pose particular challenges. And perhaps we can discuss this later on during the Q&A session, but it's a very interesting field. But let's focus mainly now on those with comorbidities, with one or more comorbidity. So the question here is the hierarchy that we saw early on, suggested by NICE, still valid when there is comorbidity? In other terms, if for a child with ADHD, the first line choice will be methylphenidate, should this be still the same if the child has ADHD and, let's say, autism or anxiety? Now, there are no clear evidence-based answers to this. I'm actually conducting a large project funded by the NHR professorship to try to answer this. But in the meantime, we have some suggestions and expert opinions. So this figure flowchart is taken from a paper that we published last year, led by my friend and colleague Steve Ferrone, and we did hopefully what I think is a very good overview of all the research on ADHD. So it is published in Nature Reviews Disease Primers, and I was in charge of the treatment part. So we put with the consensus of the group this flowchart there. So as you can see, when it comes to the choice of non-stimulant versus stimulant, the question is, would a non-stimulant have the comorbid condition? So in this case, yes, so you can choose to start with a non-stimulant. But once again, I should highlight that these are suggestions, but they are not strongly supported by data. Hopefully we will have more data soon, because I'm analyzing a lot of trials in the ADHD medication with individual participant data, which allows some modeling of this. However, I wanted also to show you this flowchart, which was part of a paper from a Canadian group in JCPP a few years ago, and they did a comprehensive meta-analysis of the literature, and based on this meta-analysis, then they came up with these recommendations. So when it comes to ADHD plus autism, they conclude that based on the evidence, still methylphenidate should be the first choice. If there is no response, then a second-line option could be atomoxetine, alpha-2 agonist, one for synchronity, or, and as a last option, actually amphetamine, because probably they are less well tolerated on average in this specific group of patients. So certainly methylphenidate still has the best profile in terms of efficacy and tolerability combined together. Another is not a comorbidity, but I want to discuss this here because it's very frequent. So when ADHD is associated with emotional dysregulation, of course, emotional dysregulation, and Olga has done a lot of research on this, is not a disorder, but it is an issue that oftentimes we find associated with ADHD. So how to manage this? Well, the best way is to do a formulation of the case to understand where emotional dysregulation comes from. And based on this, you will understand how to treat. So, if emotional dysregulation is linked to, abuse or maltreatment, you will address that rather than thinking, what is the best medication. But let's say that there are no specific causes. Let's assume there are no specific causes, and emotional dysregulation is still very impairing. What shall you do? Now, let me briefly summarize the results of this study that I think are very informative here. And I think this is a good example of how evidence-based can really inform clinical decision-making. So this was a study, a 3-arm study trial, where children with ADHD and emotional dysregulation already treated with stimulants were randomized to either risperidone, Divalproex, or placebo to understand if the adjunctive treatment had any benefit on emotional dysregulation. This was a study conducted in Texas in a university center, and they were recruiting from local camps, the equivalent of camps. When they recruited, they saw that many of these children were treated with stimulants in the community, were treated with quite low dosages of stimulants. So they did what we discussed early on. So they optimized the dose. So when they optimized the dose, they found out that, interestingly, 63% responded well to methylphenidate at the optimized dose, not only in terms of ADHD, but also in terms of emotional dysregulation. So actually, they were not eligible any longer for the trial. Actually, this turned out to be a failed trial, but still it got published. It got published in JACA because that's a very important message. So, and in the rest of cases, of course, around 40% methylphenidate itself was not enough. So the adjunctive treatment with risperidone, Divalproex were equally effective to further improve the symptoms of emotional dysregulation. Another question, once again, is not kind of comorbidity, but it's quite common. So ADHD plus cannabis, we can consider this also as an example of complex ADHD, if you wish. So there is, I get a lot of questions from colleagues, what shall I do? Can I prescribe or not? We recently reviewed the literature on this in a kind of consensus paper we did on behalf of the BAP, the British Association of Psychopharmacology. We saw that there is no really strong evidence to point to any safety issue when moderate use of cannabis, or less than on a daily basis, was associated with stimulants. But we don't know really much about more frequent use of cannabis. So, and it is possibly less well tolerated, but overall, there were no major issues. So our recommendation was that if it is not a consistent and strong use of cannabis, it is okay to start stimulants, but trying to negotiate with a young person that they stop using them. The problem is that using cannabis. The problem is that those who use cannabis may be using also other illicit drugs that they didn't tell you necessary. So we need to pay attention, especially in terms of cardiovascular monitoring. So a more careful cardiovascular monitoring. This is another kind of unexplored territory. So what to do when there are congenital heart disease conditions. So there was a kind of consensus among USA pediatricians. This is the paper for your reference. And they concluded that in mild congenital cardiac conditions, such as the ones you see here, there is no need to make a referral to a pediatrician. You can start the stimulant, but with any other condition other than this, it's always good to get the opinion of cardiology, and of course, it's always good to have this in written for medical legal purposes, of course. Right, so another situation where we can define complex ADHD is the ADHD which is refractory to stimulants, so those that do not respond to stimulants. Now, if you are interested particularly in this topic, I will recommend this paper that we wrote a few years ago with Jeff Newcomb and David Cogill. And in the paper, we find a table like this. I put here the key messages from the table, where basically I think the key message is if you have somebody with stimulant or refractory, so they don't apparently respond to stimulant, and what does it mean refractory? It means basically not responding to two stimulants. There is no a formal definition, but we can extrapolate from other fields and use this definition. So if you have this situation, before jumping to using unconventional medication or combining medication or use very high dosages, just ask very simple but fundamental questions, which are the ones you see here. So once again, where we need to use our skills as a clinicians in terms of diagnosis and especially formulation. So what's happening, for instance, what else is going on in that patient life? Are there non-pharmacological reasons for poor response? So this is one. The other one is, is the patient becoming tolerant? This is a phenomenon on which we don't know a lot, the tolerance. We know that is a phenomenon which happens in pharmacology and is when you need to increase the dose to have the same effect. So sometimes we have patients saying, doctor, this medication was fantastic the first 6 months and then there is no response any longer. That could be tolerance, but it could be a lot of other things. So this table, and in the interest of time, I will not go through it specifically, but should help your clinical reasoning. If you wish, we can go back later on during the Q&A. However, if there are no clear explanation and still, there is no response, one possibility is combining medication, as this is done, for instance, in depression or psychosis. So can we combine? What are the combinations of medications for ADHD that have been studied? The one which is supported by really evidence, even though it is not a large body of evidence, but there are at least a couple of trials supporting this, is the combination of methylphenidate and guanfacine. This is approved by the FDA, Health Canada, Australia, and so on and so forth. So guanfacine is approved in the USA as monotherapy, but also as combined treatment with stimulants. Overall, this combination seems safe. You may remember, those of you who are not so young any longer, that in the 90s there were concerns of combining methylphenidate with clonidine because there was a report of 7 cases of death. But it turned out that all those 7 children, unfortunately, had pre-existing cardiovascular conditions. It seems undoubtedly from experience, especially colleagues from North America who have more experience than us, because Wolfson was introduced early on there on the market, that it may work well, especially when there is a comorbid emotional dysregulation and also autism spectrum disorder. Right, so how long should you continue the treatment, and when should you stop it? Once again, there is no clear evidence-based answer to this. The simple answer is as long as it is needed. But a related question is, do we have evidence that the treatment works in the long term? Because all the trials we have are short term. And as I said early on, there are some patients who seem to say, this medication was fantastic the first weeks or months, but now it does not work any longer. So what is the evidence? What do we know about the longer term effect of this medication? So the problem is that we cannot, the randomized trial is the most rigorous study design to assess this. But of course, we cannot randomize somebody for 4 or 5 years to placebo, right? So how do we know? Because if we look at the effect in naturalistic samples, we follow up in the clinic, these may be biased by confounding factors that are not controlled by randomization. So how do we know that? Well, there is an interesting study design, which is called the withdrawal or discontinuation trial, which is very simple. So basically, the same individual, you randomize them then to continue medication or to placebo for a week, a couple of weeks, to see if after years of treatment, there's still a difference between placebo and treatment. And so in doing this, for instance, in this study from the Netherlands, these colleagues found that the effect size was still significant. So minus means an advantage for the medication. However, the effect size is quite small, as you can see here. As a reminder, for those who forgot statistics, effect size of up to 0.3 is small, 0.4, 0.5, 0.6 is moderate, and then beyond 0.6 is quite large. In short-term randomized trials, so at the beginning, methylphenidate, for instance, has an effect size of 0.8, which is one of the highest in psychiatry. Here in the longer term, the effect size is lower, so they are still effective, this medication, but probably, apparently, based on this trial, less than compared to the beginning. However, the problem is that when they ask patients in this trial, do you want to take part in this trial? Many of them said, sorry, no, because I know that if I stop medication, it will be a disaster. So probably they were able to select only, the mild cases for this trial. So the jury is still out, I think, in terms of estimating exactly the longer term effect, but we do know that the medication are effective. I have to say that in a less formal way, a lot of patients actually do this trial, because we all know that when they come to consultation, we ask them, have you forgot to take the medication? Many of them, they would say, yes, I forgot that particular day and it was a disaster, school teachers called and so on and so forth. So basically, we already do this kind of discontinuation trial in clinical practice. When it comes to deciding when to stop, I think that this piece of evidence that I'm going to present in a minute is very important. So basically, this is a relatively new concept in the ADHD field. When I was trained, I was told basically there are 2 types of disorders in psychiatry. There are the episodic ones like bipolar, depression, so on and so forth, and there are the chronic ones like ADHD, ASD, and so on and so forth. However, the view of ADHD as a kind of chronic and constant, so to speak, disorder has been challenged recently. The first study challenging this was this one from a colleague from United States, analyzing once again the data from the MTA. So they saw that over the years, after baseline, they had some individuals who had a fluctuating status. What does it mean? It means that some periods the symptoms of ADHD were quite evident. In other periods were less evident, a kind of remission. And possibly, the influence of stress, environmental influences are all very important in determining this. There is also now an entire line of research in women about the influence of hormones, so, periodic fluctuations of ADHD symptoms. So why am I saying this at this point? Because basically, if you have somebody who is in remission, you may think, well, actually, I'm going to discharge. Maybe the symptoms may come back 6 months later, so they will need to be re-referred. So, I appreciate that we all live in a world where the main issue is the waiting list. So, discharging is very important, but we need to consider that they may come back again. Right. So the other aspect when it comes to the management, the pharmacological management, is around, of course, the management of side effects. And it goes without saying that underestimating side effects is not good, but also overestimating them is not good either, because basically, we may prevent somebody from receiving an effective treatment, which side effect could be managed. So I always show, and probably all of you have already seen this because I show this any training I do. This is a paper we basically published a very long time ago with the European ADHD Guidelines Group, which is a guidance on how to manage side effects. I cannot go through all the side effects, but I have selected two that to me are important. The first one is the cardiovascular effects, and arguably I think is probably the most concerning one. Everybody is rightly so concerned around possible cardiovascular effects, especially when we give this medication to children. So the question is, what is the evidence on this? How can it inform us, our decision making, our discussion with the patient? We have basically two types of evidence, from a randomized trial and observational studies. So let's start from observational studies. We have evidence in the medium term, up to 2 years of treatment, and evidence in the longer term, after up to 14 years of treatment. So 2 years of treatment, this evidence comes from the ADDUCE study. This was a very important study funded by the European Union, so not pharmacological drug company. And they had 3 groups of children. Children treated with methylphenidate for 2 years, children not treated with methylphenidate, and controlled children without ADHD. So after 2 years, there was an increase in systolic, diastolic, and pulse in the methylphenidate group compared to the other 2, but as you can see, the increase was relatively modest, right, from 65, 67, 80, 83. In the longer term, there is a very nice study from Sweden with a Swedish registry. So they saw that in those individuals treated continuously for 14 years, so continuously doesn't mean every single day of those 14 years, but most of the time, okay? Basically, risk, there was an increased risk of hypertension. These were young adults and adults by 8%, okay, an increase by 8%. There was no statistically significant increase of arrhythmias, heart attack, thromboembolism. Importantly, the increased hypertensive risk was dose dependent. So basically, it occurred to high dosage beyond 40 milligrams. So this supports the recommendation that we put in our guideline from the European group, how to manage high blood pressure at the beginning, before starting treatment, or during treatment. So basically, as I guess everybody should know, we should measure at least 3 times blood pressure at the baseline with an age-adjusted cuff, of course. If the average is blood pressure is below 95th percentile, it's okay to start or continue treatment. If it is beyond 95th percentile, you have 2 options: Either you decrease the dose and you measure, and this seems consistent with the result of this study. As I told you, it's dose dependent, or you stop the medication, especially if parents and carers are quite anxious, and you refer to a cardiologist. They will do their assessment. Eventually, if they find out a pathological hypertension, they will treat that. Once the hypertension has been pharmacologically treated, then you can re-challenge, you can restart, or you can start ex novo the medications for ADHD. The second type of studies that inform us on the cardiovascular effects are the randomized controlled trials, with the caveat that, as I said, these are short-term trials. But the plus is that they are randomized, so we can be sure that the results are not confounded by bias. So this is quite complex graph, and let me explain what it is. So we did a network meta-analysis, so meta-analysis which allow us to compare the effect of different medication, even if they have not been compared head-to-head in the individual trial that we include in the meta-analysis. And the outcome were the cardiovascular parameters, so systolic, diastolic pulse, QTc, ECG heart rate, PR interval, and QRS. And then this is called a Killing plot because it reminds the Killing Doug for the, you need to have some kind of imagination, but anyway, the Killing rug, anyway. So you see in blue, these are medications compared to placebo. In blue is when the effect is worse compared to placebo. So there is an increase in systolic blood pressure in this case. And in violet is when there is a decrease in systolic blood pressure compared to placebo. Now, I guess it doesn't come as a surprise that guanfacine is the only one which is associated with a decrease. Intersynclonidine was not. But what I think is the main point of this analysis is to show that overall the changes, these are not effect size, these are raw data or raw scores, so really numbers. So this means 1 millimeter of mercury. So the changes overall with medications are quite small, at least in the short term. But as I told you, also in the longer term, things are quite reassuring. Right. So the usual question has always been non-mandatory at baseline. So ECG, should you do it or not? It has been discussed at length. Some recommendations, I don't know, in Italy, in other countries, they say you need to do an ECG for everybody before starting treatment. More at the international level, the consensus is, is at the physician judgment. It's not probably cost effective. So, but once again, if you want to do it, parents are very anxious, but you don't need an ECG for every individual patient before starting. Right, so the other side effect I wanted to briefly mention is the so-called effect on growth, because there is a lot of anxiety about this. I think is probably not justified. First of all, we need to consider that ADHD itself is associated with shorter height. So when it comes to following up a child who has been put on medication for ADHD and we found that there is a delay in growth, it is not clear if this is the effect of medication or ADHD. This is a nice study we did with the Swedish registry. It was a Kazakh experimental study. And it shows that actually the height of children with ADHD compared to controls was less compared to control, both before and after the introduction of stimulants on the market in Sweden. So, it's not just accounted for only exclusively by a medication. In the slide, I don't go in detail because it's quite boring, but you have the numbers here. These are the guidelines we published on when to refer to a specialist. Finally, this we can discuss later. I wanted just to tell you that hopefully we will publish soon, and we will then start disseminating a very comprehensive analysis of all the meta-analyses in the field of ADHD. You see, we did a lot of work on this, on the effect of any type of intervention, of any outcome we found. And based on this, we built also a platform which is meant to support clinical decision-making, shared decision-making, where, for instance, in the platform you find information on the medication, but for instance, all the type of treatments, and also information on what is the effect of these treatments. So, for instance, you see, if you are interested in the age range of children, and you are interested in looking at the effect in the short term, 12 weeks, and you are interested in seeing the effect on the core symptoms of ADHD, then it will generate a graph like this, where in green is the treatment which works well, in red the ones which do not work. The size of the circle is proportional to the magnitude of the effect, and the black circle around is proportional to the quality of the evidence. So hopefully this platform will be out soon, and you may want to consult it when it comes to the initial psychoeducation session, when you need to decide with the patient, okay, we have a panel of treatment. Maybe a patient may ask you, I want to be treated with diet. Well, let's look what is the effect of diet, and then you will discuss with that. I will stop here because I went beyond my allowed time, so hopefully there is still time for a Q&A until at 3 p.m. Yeah, thanks.
Thank you so much. That was great talk. And we've had some questions coming through, so we'll have a look at those. It looks like people are putting questions in the chat and the Q&A. I'm going to start with the chat, but if people have other questions, if you could put them in the Q&A, that would be really helpful. Okay, so the first question asks, how does dose relate to outcomes?
Yeah, so I think dose is a crucial one, really. And as I said, we should avoid thinking that high dose is always the best. So, but also we should avoid the trap of saying, since it is a child, I need to use a low dose. I remember my grandmother actually used to tell me when I was a child I had to take a tablet. Well, actually, the doctor told you 2 tablets, but take just 1 because 2 may be too much. So actually, if anything, pharmacokinetics data suggests that in children we should use higher doses than adults because the volume of distribution is higher. But anyway, so I think that dose is related in a linear way in general. So the more you increase, the better is the outcome. But this is at the group level. At the individual level, we don't know. So for a particular child, a small dose is okay. For another, you need to use high dose. So we are still doing a trial and error process in trying to find the dose. But if there is no response, you need to, one of the questions is, okay, am I using the right dose? And my recommendation would be to try to check this quickly. You don't keep somebody on 10 milligram of methylphenidate for a month. You see the effect after a few days. So, weekly titration is ideally what you would like to do.
Okay, thank you. There's another question here on doses. What are your views on using lower doses of methylphenidate in the CAMS ID-LD population?
Yeah. So I should say, and I really thank for this follow-up question to the previous. The only instance where really I think we need to be mindful and cautious and prudent is exactly in this population, intellectual disability, autism spectrum disorder associated with AD. In that case, we know that unfortunately tolerability is less good in general. So in this case, certainly I will use a slow titration and also initial dosage that I don't necessarily use with other children. So for instance, I don't know, 2.5 milligrams. You ask them to, and ideally if we start having more liquid formulation is a good way because if you start even at 10 milligrams, sometimes it can be high. And when you have a bad side effect at the beginning, the therapeutic alliance is already compromised. So say, yeah, I don't want to see that doctor because they just give me tablets, and yeah. So that's a good point. Yeah.
Okay, thank you. So we have another question here, which says the effect of ADHD treatment on other outcomes, such as emotional dysregulation, is interesting. Yes. What do you think underlies the benefit on emotional dysregulation?
Well, I would say that probably the main component is the effect on impulsivity, which is related rather than, inattention or hyperactivity. But we should bear in mind that, of course, there may be other possible explanations. So I think that when we think of ADHD, we think medication for ADHD, we think of the three core symptoms that currently define ADHD, but medications were not made with the core symptoms in mind. So medication tackled molecular pathways. So, they may have a number of effects that go beyond these three core symptoms. But emotional dysregulation is certainly very much related to impulsivity. So I would say that this probably is the key. But we still know, as I show you, at least 40% of individuals do not respond well to stimulants in terms of emotional dysregulation. Associating non-pharmacological approaches like DBT, for instance, may be an option. We have a meta-analysis under review on exactly this. Unfortunately, there are not many trials out there that can inform us in terms of tackling emotional dysregulation. So hopefully there will be more trials. This is an area we urgently need. Yeah.
Thank you. So the next question, given that ADHD symptoms can change across different developmental stages, has there been any research on how the effectiveness of ADHD medication varies by age or symptom?
Yeah. That's a very fascinating question. The problem is to study this, we can compare the effect size at different ages. So we can compare the effect size of medication in preschoolers, school age, and so on and so forth. In doing so, the caveat in doing this is that, you're not using the same study to compare the effect on different populations. You're looking at different studies, so studies themselves would have been different. But nonetheless, when you do this, what we were able to show, for instance, is that there seemed to be a different profile in children, adolescents versus adults, in the sense that in children, amphetamines seem to be less well tolerated than methylphenidate in general. This does not seem to be the case for adults. And actually, in line with this, for instance, the NICE guidelines recommend methylphenidate as a first line in children, but they say methylphenidate or amphetamines as a first line in adults, acknowledging that there is this difference. So it's a very interesting question, which should remind us that when we do our follow-up, we always need to consider this developmental effect, and at some point we may need to change the medication.
I guess as a related question with regards to sort of development, is there any evidence that younger use of medication, e.g. at 8 years, can have impacts on the physical development? You mentioned height.
Yeah, this is one of the most common questions, but the most important, of course, if you have a child, would you put your child on something that that in 20 years' time will have an effect? Unfortunately, there is no way to answer this question with studies, because it will be extremely challenging to follow up, for a long time these individuals. We do have some kind of follow-up, but the medication has been taken somehow inconsistent, but we do have some follow-ups, but they are not randomized, of course. So I think that in general, the one indicator is to what extent the medication is still on the market after several years. There are some medications that have been retired from the market because they had effect that came out later on, that were not evident, but still this medication have been there. Stimulants have been there for 50 years, so they're still here. And so I don't think that we can say, I think that the benefit outweighs the risk, but once again, is at the individual level. But it's impossible to predict this. I cannot say, what will happen to your body, to your brain in 20 years' time. That's very difficult.
Thank you. The next question is, on my current caseload, I have a small cohort of particularly impulsive ADHD diagnosed teenagers with forensic history or violence towards family members who have found stimulants hard to tolerate, but who have responded really well to atomoxetine. Is there any evidence base for this?
Yeah, I mean, this is interesting because, probably most of the prescriber in this case will use a combined low dose of antipsychotics, for instance, Abilify or risperidone, or possibly guanfacine. But once again, this is part of what I was mentioning earlier on. So what to do when there are comorbid conditions, in this case, ADHD plus kind of conduct disorder or severe ODD. So atomoxetine, so far all the data we have is that is mainly helpful when there is a comorbid anxiety, and it doesn't seem to touch a lot the outcome you mentioned, but it's interesting that you find this. So now, of course, this is the difference between personal experience and evidence. So personal experience, by chance, you may have seen 3 cases like this, and then you conclude, of course, this is the rule. But if you look at the evidence from 20 trials, maybe they may not support this. So it's something that it will be interesting to discuss with other colleagues to see their experience. In my experience, this has not been the case, I have to say, with atomoxetine. But I don't use atomoxetine a lot, I have to say.
Thank you. So the next question asks, could the hypertension risk seen in 14 years use of stimulants be attributable to other factors rather than medication, lifestyle and dietary choices with impulsivity, for example, patient weight, etc., etc.?
Yeah, so this is absolutely true. So actually, I should say that in that study, they controlled for this. So even and despite after controlling for this, they still saw an effect related specifically to medication. But what you say is absolutely true in the sense that there is strong evidence that ADHD itself is a risk for cardiovascular disease. Without there is a paper we published in World Psychiatry with the Swedish group a couple of years ago, and it shows exactly this. So once again, I think this tells us something which is very important in the clinical practice. When something happens during treatment, we cannot really attribute this to the treatment necessarily. We say, okay, it may be treatment, but it may be also other things.
Thank you. So there's another question here that says, your platform graph looked like there was good evidence for dietary manipulation. What specific dietary measures are effective, and should we be recommending this to patients?
Yeah, so I should say, first of all, that was a kind of prototype, so we need to check the green and the red. It was just to show, but actually diet gives a good effect, but so this is why it was in green, but the effect size is very low. So, it's not just helpful to look at if it's green or red, but also the magnitude of the effect size, because, an effect size of 0.2 means that statistically it's significant, but clinically you don't see a lot. So so I will not endorse this. Good diet is good for everybody, but we cannot claim that it is a treatment for ADHD.
Great. Thank you. I think we've come to the end of the questions there. Perfect timing, just turning 3 o'clock now. So thanks once again for such a great informative talk.
Well, thanks everybody, and I look forward to staying in touch with you in meeting somewhere. Thanks very much.
Thank you.
Bye. Bye-bye.
Thank you.